I'm Eric Chemi, and this is Politely Pushy. Welcome to Politely Pushy. I'm your host, as always, Eric Chemi. Today, we are joined by Todd Eury. He's got many roles. I feel like you're one of these multiple slash people doing a lot of things. The main thing that we can talk about today, you're the head of the Pharmacy Podcast Network. You're a podcast host in your own right. I'm sure know more about podcasting than I do, which is impressive. That might be the first time I've interviewed someone on the show who knows more about podcasting than me. So Todd, thank you so much for joining me today.
Thank you for having me, Eric. And I actually disagree. I come right out of the interview and we're already disagreeing. I actually don't know a lot about, I would say, podcasting as in and of itself. Like, I have difficulty with the whole RSS feed situations and things that are happening. And thank the Lord for my support team. But what I do know is I know how to take the traditional communications that has been part of humanity forever, since language was invented or discovered or whatever that is. We could do the philosophical question comment on that. But I think what I have been really good at, and as a first, obviously in the pharmacy profession, is taking podcasting specifically as the pen. And as the deliverer of the communications. And I've taught a lot of people, more pharmacists on planet Earth have learned to podcast from me and from what we do than really anyone, which is fun to say that because I call myself the Rx Podfather. Because I'm so passionate to get communications out to B2B, to pharmacists to physicians, pharmacists to nurses, pharmacists to educators, to teach them that you can take so much of what you know, put a good quality, that's what I said, people out there, get a good quality mic and talk about your mission of what does it mean to be a pharmacist. That answer, Eric, is not what it was 10 years ago or 20 years ago, because the new age of pharmacy is here and I'm podcasting it.
So first off, I go on your LinkedIn. I don't see you ever having been a pharmacist unless I'm missing something here. So how did you get into this? If I go way back, I see, hey, you had kind of corporate jobs and they were in the telecom industry, but nothing about either being a media host or a pharmacist. So how did you get here?
Yeah. It was the stoniest, windiest, crappiest pathway to get where I was in so many ways. And my entrepreneurial spirit's been around since I've been young. Probably, I think 10 was my first concept of an idea. It was called Sink or Swim. And Sink or Swim was to teach kids that were afraid of the water how to swim, but do it in play. And so as a 10-year-old, I hung out at a neighborhood pool. It was a very nice pool called Penn Valley in Western Pennsylvania. And I like these kids. I like these 5-year-olds and 4-year-olds, and usually 4 or 5, 6 years olds, not 3. I don't want anybody that's in a diaper or coming out of that or anything. And we'd all be in the shallow end of the water, and they'd be all scared, or they'd have the stupid floaties on. And I'd get them to take the floaties off and just play. And I started teaching them to swim in playing, and I called that business Sink or Swim. I think I was my first business. And so you put me into telecom, somebody that's so hyperactive, and I really liked telecommunications, did it for 8 years, but I hated it because it was transactional. There was no spirit in it. There was no joy in it. It was
so you liked the content of it. You liked the stuff, the components of it, but you didn't like the function that you had. Is that fair to describe that?
There was nothing creative about telecom, Eric. I mean, we're talking about frame relay. This is before internet. I'm getting old, Eric. This was before internet. So everything was being delivered by something called frame relay, which was private networks that were set up for small, medium, and these conglomerate international businesses, private lines, private communication lines. And then when the internet sprouted and the .com gold rush took off, that's what got my mind thinking about the future. And I was like, wait, this internet thing is freaking wild. And this would have been like 1999, 2000.
It's like what people say right now about crypto or AI. Like, this AI thing's really wild.
AI thing is crazy. And we're going to look back 20 years from now. So I took a leap of faith, was making a ton of money by the time I hit the 2004 era, and was miserable, and had paid off my small little house out of small town where I was, and I said, that's it. I'm moving into healthcare because I heard that that's really a future, and I can be more creative in it. So I took a position with a small software company that focused specifically on long-term care pharmacy software, and was the first software system that was built on SQL, which was unheard of, meaning you could extract your data and put data in, take data out, do things with the data. Back in the day before that, these were closed computer software systems that you could only do a label, or you could only manage width per minute. There was nothing discussing. There was nothing being shared. It was all internalized. So put me with this hyperactive way of thinking, and I started creating workflows in my mind, and I started working with long-term care pharmacies and started digging into their businesses. And it just opened up my brain that I'm like, oh my gosh, like there's so much to be done here in this industry that's crippled by the most intelligent people that are out there running these pharmacies aren't good at marketing. They're not good at thinking outside their box because they're keeping people alive, for God's sakes. Our pharmacists keep us from dying every day. People have no idea how many
If they do it right. If they screw it up, then
That's true. So it was my job to it was to help take them to another level. And I was doing that through blogging at the time about all kinds of technology stuff, about different interfaces, and people didn't know what APIs were. And I had this wonderful blog. And then I started traveling a whole bunch for work. No time to blog. So I said, that's it. I'm going to start this stupid thing called podcasting. I did it on Blog Talk Radio on March 2nd.
I remember Blog Talk Radio. I remember that. Yeah.
It was horrible. It was March 2nd, 2009. The very first episode of any podcast about the profession of pharmacy went out that day. It was the very, very first one. And from that point forward, I said, that's it. I'm going to start communicating with my profession through podcasting. And then in 2012, I was like, that's it. I'm going to take pharmacists who are brilliant, that no one's telling their story, and I'm going to build a network for them. And I'm going to make this the biggest podcast network dedicated to our profession. And here we are, #1 in the world. So it's fun to be in this position, but it's also scary.
#1 in what ranking? In podcast, in pharmacy podcasts? Like what is the ranking here?
The ranking is we're the only network on the globe that has done what we've done with podcasting, from continuing education to first to deliver continuing education through podcasting, first to partner with national associations who desperately need to know, how the hell do we podcast? We don't know what we're doing. The first to attend conferences at a podcast covering as press. The first to gather up pharmacy students and teach them about different components of learning because they're sharing information together through podcasting. And the first to deliver the Naplex podcast, which was the podcast dedicated to our students that were getting ready to take their final test to become a pharmacist. So we've done so many firsts, and it's not because of me. It's because of those brilliant pharmacists that just needed somebody to herd cats and to put things together and to market it and to believe in it and to really blow them up, because they've never had someone that has been dialed in, or there is no such thing as a pharmacist talking head who has been able to take so many facets of our ecosystem, of the healthcare ecosystem and what's happening, and put that into podcasting.
Who is the audience? I mean, I have so many questions, because I'm going to say a bunch of questions right now, and then you pick which question you like, and then we'll go from there. When I think pharmacy, I think, okay, all the stuff going on right now with Mark Cuban and Cost Plus Drugs and Amazon getting into pharmacy and all the online pharmacies that are competing against both mom and pop and then the big chains, right? And then I think about mom and pop is struggling to fend off the giant chains and these online disruptors. Then I think about, okay, you've got a network of podcasts. How many of them are you hosting versus you're the business person helping them set up? How much need is there for multiple pharmacy podcasts? Do you all work as competition, or are you working together? Because how much time can someone have listening to pharmacy podcasts? Are you cannibalizing yourselves? And I'm curious, where is that studio? Is that in someone's house in the basement, or you have a real studio somewhere? And I'm curious, when did you make this your full-time job, as opposed to, hey, I'm doing this on the side while I do something else? So these are all the things coming on in my head, and I don't even know in which order we should attack these things.
I love it. Those are great. That's a whole story. I should write a book. So I'll start with my wife, because God bless her for putting up with me. And at the point in my life where I'm like, okay, that's it. 2018 rolls around. I hated it and I loved it. I hated the Pharmacy Podcast Network, and then of course I loved it. The hate came when you worked a 60-hour week and you were traveling all over the nation in doing things, and then you had to get home on a Friday and you had to build out 3 or 4 podcasts by yourself, edit them, organize them, market them, put them together, do everything. I was a one-man band, and the money that was coming in to support that side hustle, that publication, was wonderful. It was finally paying for itself. It was giving us a little extra. And of course, the wife, my wife liked that too, a little more extra, maybe vacation time and paying off bills. That's great. But there was no way for me to serve 2 masters and be able to do that. So I told her, listen, I want to do this. Like, if I don't do this right now, it's never going to happen. Podcasting's finally getting popular. It's time to do what our strengths are and really support the industry and support the profession, just like the NCPA. Do you know what the NCPA is?
I know what a CPA is. I don't know what it is. My parents are CPAs, but I don't know what the NCPA is.
Yeah. So the NCPA is the National Community Pharmacists Association. So that is the association that focuses specifically on independently owned pharmacies. Then you have the NASP, the National Association of Specialty Pharmacies, or the APHA, which is the king that rules them all, which is the American Pharmacists Association.
These are all the trade associations or the lobbying firms. They're probably all DC based for the most part, is my guess, right?
Exactly, most part. And they kind of do more than just DC and public relations, but they're doing things to really change the profession. They're working with boards of pharmacy, and they're doing. So I'm the first association of sorts that has taken podcasting as a media form and have done things with it within the profession that have never been done before. And then I'm creating, not me by myself, I'm creating through my pharmacists levels of authenticity, levels of trust, and then the ultimate level is called evidence-based podcasting. That is something that we've invented from day one, which follows a very specific guideline of assuring that what you're listening to is in fact just as good as reading a journal article. But for God's sakes, I'm driving 45 minutes to work 2 ways, and I have no time to read because I got to get home and get soccer and, spend time with my husband and, go out and do whatever I'm going to do. Who wants to read a journal article on hyperlipidemia, some blood disorder, and a new titration of a medication that's come out and blah, blah, blah? No. Let me listen to a podcast that's just as good as a journal article that has been reviewed, peer reviewed, checked up on. And I'm like, as soon as I listen to that thing, I'm good. So we've attracted organizations like Novo Nordisk and Moderna and the APHA and the NASP and all these organizations that are like, we trust this organization because it is the highest level of podcasting. That creates a vacuum of attraction. So we're getting pediatric focused pharmacists. We're getting long-term care geriatric focused. We're getting rare disease focused. We're getting marketing. How do I market my pharmacy? We're getting entrepreneurial podcasts to teach the entrepreneurial pharmacist how to. So it's an entire portfolio of podcasts that's been captured, the essence of these wonderful people who are doing so much more than what the public realizes a pharmacist can do or do. And we're taking it up a level, and I keep adding things onto it. We're adding on HLTH, and we're adding on, which is the biggest, fan-based health conference. It's like the new collaborative digital health conference that's out there. We're adding on HIMSS. We're doing things that, once again, podcasting has never done before. Press. The funniest thing, when I asked for a press pass in 2015 or 16, and they're like, "You're what? Like, you're a podcast? Get out of here. Like, you're not coming to the."
We meant real press, not you guys. Yeah.
Like, what are you talking about? But now I'm looked at by these organizations where we actually run their press. podcasting stations.
How did you fight through that though? What made you not give up or think, hey, they're not taking me seriously. They don't see what I see. And you've been doing it for years and that was years ago. What gave you that stamina to fight through all that?
Because I saw what was happening in the consumer world. And by the way, we're staging for an overtake, which is going to be wonderful. So if anybody's listening that wants to be part of this revolution in audio learning, we're going to go after consumers, because consumers learn bad things from bad information that's out there. We know that. We know what happened during COVID. We know what happened and there's going to be sources for the public accessing some of the most brightest minds in pharmacy who don't get any attention because they don't have big PR agencies behind them. But what you are asking is, how does it how do I not get burnout or whatever? And what that is I saw what's happening in consumer, and I saw how podcasting is just blowing up. iHeartMedia is leading. They have a new division called Ruby. We work with Ruby with some of our collaborations. We're working on a special new project with them actually right now. And they have honed in to using pharma, which is so boring to listen to in some ways, if you read those inserts, those information inserts, and they're taking stories, real life patient stories, and they're delivering to the market some really interesting podcasting, but that's from a consumer perspective. I'm all about the HCP to HCP. So we perfect this, and then we're going to go to consumer with the HCPs helping to tell those stories. So you hear it from the greatest source of medication management. You're going to hear it from the mouth of a pharmacist who does nothing but works on that. What, Eric? Well, the geriatric show, the pediatrician show, the collaborative HCP show, the cancer show, the oncology show, the HIV, especially rare disease show, whatever it is. We're going to have these specialists that are going to be able to give our public a reassurance of what I'm listening to is timely, it's updated, it's from the latest journal information, accessible, it's evidence-based. If we even want to go that far, we have to get sponsors for that level, by the way. So shout out to the sponsors. But if we get sponsors that can fund us, we can grow more and more content to connect that with public relations and the public in and of itself to really change the game and allow this to be the Facebook of podcasting for the entire pharmaceutical market. And that's because it's not me. I'm not going to say no. As long as you aren't a wackadoo and you can back up what you're saying, especially if it's medically driven and clinically driven, then back it up, guy or gal, or whoever you are. I'm ready to go. But I don't want to ever stop somebody from talking about something that would be controversial and bringing it to I think transparency is the new form of healthcare. And Mark Cuban, you mentioned him, shout out to Mark Cuban and Mark Cuban Cost Plus Drugs and Dr. Alex. They are doing things that are really going to help change the entire pharmaceutical marketplace. And I want to be the podcaster of it all.
Who are the good guys and the bad guys? Because I feel like as a consumer, right? I've never worked in a pharmacy. I kind of skittish and squeamish around health stuff, so I kind of stayed in the math computer lane and not in a biomedical lane. So I think a lot of people just they don't know. They know prices are high. They feel like insurance companies are screwing them. Maybe the government is helping or not, but it's all political statements. Who is the good guy in the industry and who's the bad guy in the industry?
That's an awesome question, Eric, and it's both. So we are human beings, okay? And there are organizations that are that are taking a lot of punches in the face right now because they deserve it, and that's called the PBMs, the Pharmacy Benefit Managers. And it's only 3 pharmacy benefit managers that are very specifically the culprits right now. But inside those organizations are some wonderful people and are some people that are dedicated to patient care. And there are pharmacists that work with CVS Healthcare, and there are pharmacists that work for Optum, and there's pharmacists that work for Express Scripts. And these people are part. And so when they hear their business being shunned by the government and investigations, and the public finally is starting to pull back the wool from understanding what the hell is really going on. Why are drug prices so high? It's not the pharma manufacturer. I mean, they have obviously some play in it, But the major culprit, the one that set the stage of how to manipulate pricing and formularies and rebate games and shell pricing and gag clauses, which will blow you away what they did, 5 years ago when the Congress finally got rid of that. A gag clause, Eric, meant that if you went to your pharmacist, any pharmacist, community, chain, and you said, hey, this is my XYZ medication for whatever. It's my statin. Okay. I got, cholesterol, whatever. All right. So here's your stuff. Oh, by the way, you're Eric. I'm the pharmacist. And you say, hey, pharmacist Todd, can I get a lower price anywhere else on this? So by law, pharmacists were never allowed to recommend how to get a lower price, how to save money, do whatever. They had to just stick to these contracts. And these contracts were all about the PBM making as much freaking money as possible. And then now what's happening is they're making so much money that they're undercutting. Did you know that pharmacists and especially these community independent pharmacies literally lose money on about 30 to 40% of their business per year in the way that the shell game and the rebate game is extracting money, and they're charging the patient something, they're charging the insurance plan something, and then whatever's left over, the pharmacist gets as a dispensing fee. And these dispensing fees are negative 83 cents, negative $8, negative $800, negative, where they're paying to do business. So has that ever happened in the history of medicine? And I think the answer is no. So that's where the revolt of the PBMs is happening right now. If you go to the PBM Reform podcast, which is one of our podcasts, PBM Reform podcast, it gives you insiders. It gives you the insider talk of what's really happening. Like, I want some freaking PR behind that show, because it would really help the public to understand, holy crap. Now we know what the truth is. And it's the stories that are being told by the insiders, not me. It's them that are telling the stories. The pharmacists, the pharmacy owners.
I'm looking it up right now. Here we go. The PBM Reform podcast. How can there be so many podcasts like PBM Reform? There's one about, this political talk RX, but then there was another one that related to law and policy. There's a lot of ones that have these overlapping concepts. How can you make so many different podcasts that are kind of hitting on only a few broad themes?
Yeah, it really teaches you about how complex the healthcare system is.
Right.
You start getting granular into very specific things, from clinical diagnosis and treatment to management of disease states to clinical trials to legal and illegal marketing of compounding prescriptions. And so when you start splitting the hairs, you realize how important some of these individual issues are. And I want the love of my profession. I want them to be able to tap in to very specific segments. And sometimes these are only series based. Maybe they're only like a 6-part series or a 12-part series, and then they're done and we move on. But at least there's information there for them to really dig into what we see as some of the most important issues that are happening today. And sometimes it's a patient specific discussion, like Dr. Jenna Quinn, who is our pediatrician focused podcaster. And she and her entire 4-doctor team develop these amazing discussions that they dig into the weeds of some things that are happening to the poor pediatricians out there who are stressed out. And now they're becoming the sources of vast information in medication management, specifically for our most fragile of patients, these poor babies that are 2 pounds in a NICU. And you dial in as a pharmacist and you're like, wow, I'm going to really pay attention to the sensitivity of this subject, because who's listening? Other HCPs, nurses who take care of babies, and these beautiful pediatricians that have all this stress on their shoulders. And it's the pharmacist that's the right hand when it comes to that sensitive medication management. So we could keep building. Like, I only have 42 active podcasts right now, Eric. Only
42 active podcasts.
Yeah, but I want this to go into hundreds, because I want specific things to be developed from specific perspectives. We're missing the patient journey of all of this. A shout out to Matthew Zachary, who was the inventor of Cancer Sucks, and just his entire empire of publication from the patient perspective was amazing. And it's to think where we have to go next is really, I wanted to be drawn more to the patient more than ever. We have enough subject matter expertise in the pharmacist category, and I'll continue to grow those, but it has to make sense. I have to listen. We've said no to a lot of podcasts over the years because I either saw that there was a short vision for it, or I talked to the person and I tested them out and being a guest, and then of course they died out. Because, by the way, people, God bless them, 5 million podcasts out there in the world. Only, I think, a tenth of them, if even that, are truly active podcasts. And it's because people think that they buy their Yeti mic from Amazon for $99. And by the way, back in the day when I bought this, it was $325. It was 2010. These things were expensive back in the day. Podcasting has become so popular. People are like, I'm going to buy buy a microphone. I'm going to be a podcaster. Well, God bless your heart. I mean, go to town and do what you're going to do. But they quickly find that to produce something that is quality, thought through, show notes, graphics, marketing, connecting it to other things.
It's all the other stuff. It's all that production and admin that is totally a different function than being a host.
True.
Right? I really dislike all that other stuff. Like, I'm just happy to talk and have conversations and ask questions and be with the person. But as soon as you go down that whole other world, and you need to do it, or someone needs to do it, so it's either your time or your money.
Yeah.
Or if you don't do it, then no one's going to find you, right? If there's no show notes, there's no transcript, links, descriptions, where's the headshot, where are you uploading it properly, did you edit it, where's your intro outro music? It's more time doing that than actually to do the interview.
It's true. Yes. And to keep it going. I mean, right. I say to our host, you have to promise me at a minimum that you're going to be here 12 months from now. And of course they're all smiles and excited and they're smiling. And then all of a sudden month 6 hits and I'm like, dude, where is your monthly episode? Because I go on frequencies of 30 days usually. And unless it's a special series or something, and they'll be like, oh my gosh, I'm so busy. I'm like, I know you're busy, but like you made a commitment to this. You have to keep going. It's like I'm your like gym spotter or your trainer. Like I'm like, let's go, pump it out. Like, let's go. And then when you blow past that period of that 1 year, that 2 year period, it starts to become almost addictive. There's a lot of podcasters out there that are the hardcore OG podcasters like Joe Rogan. Joe Rogan is just what he's built as an MMA fighter, and he built his brand and everybody thought he was a meathead, but he's one of the best interviewers I've ever heard in my life. And he has to be with how successful he is. And I look up to that, but think of this. It's the element of digging down in an intimate way with your audience. And that's the key to podcasting, is being as transparent and as intimate as possible with a niche. And you have to pick a niche. You have to say, where do I dial into? And I accidentally picked pharmacy. I mean, I didn't do this on purpose. I'm not going to ever say I'm some brilliant guy. Like, I just know I'm the master jigsaw puzzle piece put together, and I'm the Rx Podfather now because I see the matrix of all where this is going to be able to go. And there's a lot of money behind it. And that's the exciting part, because I've been doing it for 15 years and I'm still in the red.
Oh, for real, you're still in the red.
Well, I mean, if I took up all the money that
accumulated from day one in the red, or the annual, still like this year would still be in the red.
No, I'm okay this year. But I mean, if I were to, my poor wife, if my wife was like, have you ever made up which we've all put in? And I'm like, not really. Like there's still those times where I was chunking in money to get this going. And I don't really look at it anymore because I'm always a forward thinking person, but it's now being blended with public relations. And that's where I'm going. I've learned so much from Fin Partners, which was a great teacher to me as a public outsource, trusted news source, trusted way of getting information out there. And now it's time to grow this. And we're going to be doing combos, and we're going to be working with other publications. We have partners that we're aligning contracts with right now that they're like, why am I doing this myself when I could just partner with the PPN and dominate an entire theme, whatever that theme is, and I've already baked in 60,000 listeners per month. Like, are you kidding me? Like,
Yes,
why?
so how does that work? So give me an example. So let's say, so who would be a possible, let's say, client of yours? Would it be someone who's in the industry, some company? Let's say I'm a pharmacy chain, or I'm a PBM, or is it, let's say I'm someone like that, right? Is that who might come to you and say, hey, we either have a podcast right now, but it's not going anywhere, or we want to start one. Can you help us? What would the transaction look like? They're paying you guys, and then you get it on the network because you already have the pharmacy audience. Like, what is, just help my business mind think through this.
Yeah, that's an awesome question. So, multiple things within that. So, first of all, I would ask if someone, let's take an insurance company, for example, a PBM, a transparent PBM comes to us and says, hey, we want to start a podcast. And I'm going to say, why? Like, take me through the marketing plan, take me through the infrastructure of what you already have out there and your brand and your mission, and take me through all that first. Like, we're not podcasting yet. And they're like, all right. And I'm like, all right, I take them through, there have been times, Eric, where I have said no to businesses that wanted to give me money. Why? Because it was going to be a reflection of my failure as someone who 3 months out or 6 months out or 9 months out had died off. And now I got to actually do short-term projects with the same organizations who are now paying us on a regular basis, but it's more of a project thing. And they're like, okay, because it's a lot of work, for God's sake.
So you're saying instead of committing to an ongoing perpetual podcast, just say, let's do a 6-episode series of 10. So we know there's an endpoint and we can complete that. Where you're right, because a lot of people think, I'm going to do a podcast, I'm going to do one a week forever, and they're toast in 3 months. Whereas if you just said, I can do 10, then you get 10 done.
That's right. And it feels like a win. We get the money out of it. And then we show proof of concept. We also blow it up where they're getting downloads that they'd never get. I think the average, you go to Google right now, put in Google, what is the average number of downloads in 30 days for a podcast? And I think it's 141 listeners. Okay. So that means if you get 141 listeners in 30 days to one episode in your podcast, you are on average. Okay. So we're getting somewhere between 600 or 800 per month. And we're this micro podcast that wants a specific audience. I'm not after necessarily yet the consumer audience, not yet, but it's coming. But right now I'm after the pharmacy profession.
Right, that's a very small niche. So if you're already getting above average numbers, but only going after a small niche, then you're getting a huge proportion of the people who care about that niche.
The number one in the world, number one. And so
who's number two? Who are you competing against?
So there's wannabes. It's hard to say because there's publications out there that are here. This is strange. Listen to this, Eric. I have a publication out there that is my competitor, a really good competitor in ways, not podcasting. They're my client, and then there are a bunch of my friends. So it's like I want them to win, but I want them to stop trying to podcast and just give it to me so I can do it for them and then white label it. Because I do that too. And then, by the way, the internal podcast, shout out to everybody listening right now, the internal trainers podcast for taking an HR manual or taking a sales process or taking a marketing process or a president's message. The future of the internal podcasting is going to explode. Like when people
internal within a company, you mean? Like the audience is only our actual company. We don't want anyone to hear it. I see it's a training manual. It's standard operating procedures. We don't write it up anymore. We just do a podcast and listen to it and you'll be all set.
There's a very few companies. I know of one. I'm not going to say their name because I want them to work with us, but they are internalizing podcasts, and it's standard listening, meaning you have to go into your HR thing because you get an email that says your podcast is due to listen to within the next 3 days or something. Like you have to listen to it. And that is driving assurance of policy and strategy and marketing messaging and communication. And it's just brilliant that whoever came up with that. But the reason why I shout out is because we're already starting to do it in the pharmacy market. We're going to be working with some buying groups. We're going to be working with some of our clientele. I could see some of our other organizations realizing, holy crap, I could sit down as a CEO or as the HR director or as someone in clinical definitely clinical, and do a quick 10-minute, 20-minute update. Hey team, it's Todd here, your VP of clinical. Listen, we want to talk about the H1N1V1P1, vaccine or whatever, and blah 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 blah. So it's. I think podcasting I think we're still in that new age. It's the .com gold rush, and when everything settles down, I'm going to still be here, but at least we'll have like this infrastructure in place to really help people take it from 0 to 80 miles an hour within an overnight realm, rather than you saying like, go, please go, Eric, go start you know how it was, go start a podcast right now. And God bless you of how long it's going to take you to grow it but if it's a hobby, goodness gracious, do it. Cause there's something about podcasting, like I said, about podcasters that are into it, that it's very therapeutic, and it's a great way of getting information and ideas out. But from a business profession and from a authority perspective, and a medical perspective and clinical authority perspective, this is where it's at.
How do companies, let's say they don't want to start a podcast, let's say they want to just be featured on it, or they want to be a guest, or they want to be mentioned, they want the PR value, but they don't want to do the work, if that makes sense. What's the in for those guys? Or is that even a worthwhile approach to do it on such a small scale?
It is. I had to create that almost 2 years ago, and it was called Twerks. So if you want to Twerks, TWIRX. If you go ahead and Google that as a hashtag, if you Google hashtag Twerks, you'll find a lot of twerksing going on. So Twerks stands for This Week in Pharmacy. And so This Week in Pharmacy is that magazine style catch-all show that I can easily test ideas on. I can experiment with people's ideas around what they're talking about in the evolution of pharmacy care. We can preview organizations that don't want to take on the full commitment, because I'm very, when you sign our agreements, like I become the weight trainer, the bodybuilding trainer, where I expect you to make this part of your communications and PR strategy. It becomes part of the whole thing. So giving them the twerks and giving them the opportunity to experiment on This Week in Pharmacy is a great way to usher in new things. But then it's also delivering something that's never been seen in the pharmacy profession, and that is a weekly show that delivers updates every single week. That's very timely. We're talking about the news. Sometimes I have news come up within 30 minutes of publishing, and I'm like, holy cow, like this, I have to get this on Twerks. So we try to get those out every Friday. Sometimes when I go to conferences, we're not able to get it out, but for the most part, it's every single Friday a new Twerks will come.
How many shows are you hosting then? How many different podcasts are you the host of?
So I hate hosting. I want to disappear. I do like Twerks, to tell you the truth. It is fun. So that's my one specific show. And then I'm a guest host every once in a while, because we'll have a lot of clients that will either their host has something going on, usually a pharmacist. So I'll jump in for them. That's happened on a couple occasions, like with SoftWriters, which focuses on pharmacy management software. By the way, the company that brought me to pharmacy, I was with them for almost 4 years, called SoftWriters, out of Pittsburgh, the first pharmacy software system dedicated to long-term care pharmacy on SQL. They are now a client. So I came full circle and it's amazing to see how they're using podcasting to differentiate themselves and educate the market to a very specific sector of pharmacy, which is our geriatric senior care. And that's exploding. Like if you think of how many baby boomers are coming out over the next 20 years, how intense that's going to be for our healthcare system, we have to rely on our pharmacists to kind of make up some of that, that the physicians they're under so much pressure.
And then mention again that you're like the weight trainer. You're the one pushing. Is it typical, let's say a company says, we want to start a podcast, we're going to run it through your network. They're providing the host, and then they're bringing the guest, and then you guys do the production? Or what is the typical flow of that?
I have so many versions because we're very custom. I give someone, if someone asks for a proposal, it gives them a menu of options that are just like black and white. And I'm like, listen, you can take these things and make up your own thing. So the FDA podcast through us, the freaking FDA, like pinch me. Like, I can't believe that's even a thing, but they wanted to get a series out to pharmacists. We're having a hard time doing it because guess what? Getting an audience to listen to your podcasts. And if I said, you want to listen to the FDA podcast, I'd probably say no, because I would think that would be, boring. But when I started listening to what these brilliant people in the FDA were trying to communicate to other healthcare providers, it lit my head on fire. I'm like, I got to get this content out to them. And so I put an entire campaign of taking something that was already done, and all they wanted was marketing and distribution and connection. And I did it for them. We had it was a home run of a series, and it's wonderful. And I'm so proud to say that the FDA, it's like a love-hate relationship. There's things that the FDA have done, just like all the humans that we were just talking about. There's good humans in organizations, and there's weirdo humans in organizations. But the division of the drug division within the FDA is just filled with some of the most brilliant and passionate people, and it was so much fun to work with them. And I was so proud to get that out for them, because I felt like I was serving my country in some way, or the government in one way, and helping to get their messaging out. It was fun.
I was just about to say thank you for joining us. Thanks for coming on. But then you just mentioned the FDA, and I just wanted to ask before we go, how much are you navigating regulatory issues in terms of, you can say this, you can't say that? We see that with banks, for example, right? Or certain financial firms, you can't say certain things. How much of the regulations affect what can be communicated on these podcasts?
That's an awesome question. So me, which is kind of my weakness and my strength. Okay. You asked a really good question about 17 minutes ago. You said, hey, you're not a pharmacist. What's up? So because I'm not a pharmacist, that is my superpower. I can literally say anything into this microphone right now, and no one can sue me, because I'm not a pharmacist. I am a consumer. I have freedom of speech to literally say anything I want to say. Now,
right, you have no license that they can take away from you.
That's correct.
Yeah.
And that's a power. And this network is a power, because I'll push any message through that a pharmacist brings to me that I can find validity to, obviously. But there are pharmacists that have pushed messaging through our platform that did not want to be named. And we absolutely did that, because I wanted to service and be a gong and an amplifier for that pharmacist and for those pharmacy voices. There's not a lot of that, by the way, because they check and balance themselves internally. We're not coming up with any like super controversial things per se, but it's fun to be in my position in some ways, because I don't want to feel muzzled if I want to discuss things. And that's where Twerks comes in. Twerks is This Week in Pharmacy. I get to give my opinion on things that are happening in the news. I get to give my educated opinion on like stuff that's changing, maybe in policy and regulation. I really stay away from the clinical, because that is where the thickest of weeds are, and I don't belong there. I'm not a clinician, and I have no right to. I can give like a flippant opinion about nitric oxide. I'm taking a nitric oxide now that is supposed to put more oxygen in your blood, and I think it's working. Like I'm peppier, and it even helps with erectile dysfunction. I guarantee it, because I've noticed the difference myself. But yeah, it's like, who would talk about nitric oxide? How could we get the public to understand, how does nitric oxide interfere with statin, or how does it interfere with a blood pressure medicine? Blah, blah. Well, guess what? There's probably a podcast out there on that, and a pharmacist is probably somewhere on our network. I know there actually is. I think we've done an episode on it.
Do you have time for 2 more questions? I know we're running a little long. Okay.
No, we're good.
Because you mentioned, so I feel like the Joe Rogan that I could sit here for 4 hours and talk to you, but I know we don't have 4 hours. But why are people getting sicker? Why do we rely on pharmacies even more and more and more? Is it what we're eating? Is it like what's in the water? Like, what's happening to us as a country that in a way, the pharmacy industry is becoming so big and important as you see, but it means because people need to take all these medicines, right? So it's like, if you step back, why are we getting so sick?
That's a really good question. Like first of all, I don't have a good answer, because I am not a clinician, although I'm an observer, and I'm an opinion. I have an opinion. Like, I have my opinion. I guess I could give you that, and it's all in it. But some of my opinion is really based on papers that I've read. And
what's your opinion?
Journal.
What's your educated opinion based on what you've read?
So I think there's 2 things. Number one, we've allowed our food system to get freaking hijacked. I don't know when it happened. Maybe it was in the 80s or the 90s when corn syrup and so much of this processing started coming in. It was all about money, 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 money. And we got away from, cooking our making our own breads and doing things that were more natural driven. So that's number one, is that side of the world. And then let's talk about pharmaceuticals. So today there are more NDCs, that's national drug codes, than ever before. Okay. And the reason is because back in the day, your pharmacist would, let's go back to 1850. You went into a pharmacist and they would grind in ingredients, herbs, and a little bit of this thing, and some cocaine and some aspirin, and they'd grind up this thing because they knew the breakdown of how a human being was going to react to what they were compounding, right? And then they'd say, you know what, a lot of my patients are suffering with what I'm grinding up, the succotash, drug that they made or something, and they'd take it and they'd put it in these little boxes that would create capsules or would create little round circles, and then all of a sudden they'd start putting those in jars because someone, their community was having the same ailments, right? And then all of a sudden the industry took hold. I'm not sure when this happened, probably 1920s to 1940s, where the pharma industry was kind of born, and they're like, wow, instead of our pharmacist with ingredients doing all of this custom compounding, let's just make it. Let's make it. So now you'll see in the news that there's a battle between pharma and compounding pharmacy, because there's still a desperate need to compound things differently for that tiny baby, or you, Eric, that doesn't metabolize medications the way that they've been designed. Me, I metabolize super fast. So we're being given the same freaking drug. You and me are taking the same drug for the same thing, and you're processing it completely different than me. That's where a pharmacist comes in. That's the future of pharmacy. I don't want to see us increase the number of drugs that are out there. I'd actually like to see that decrease, but that's a whole nother podcast. What I'd like to see is pharmacists doing a lot more dialing in. And there's a ton of pharmacists, Eric, out there who are de-prescribing, because they're the medication experts and they're looking at what the doctor has going on, or 4 doctors have going on, and someone's on 18 medications. And this medication, the only reason that they're taking it is to combat the outcome of that medication. So really it has no, meaning of even being in your system. So understand, what did I say about humans at the beginning of the show? There's good and there's bad, right? There's some pharma companies out there that are just freaking evil because they're greedy, right? But then there's some pharma companies out there, which I like to think the most of them, they see a mission to help people live better by either eradicating disease or inventing something to keep us alive based on having such a horrible disease and condition. And I think there's an ebb and flow, and there's a fight between good and evil, actually everywhere, really. and in this world where we're so highly medicated, there's pharmacists out there, and the majority of them that are out there that are like, this sucks. Like, you guys should not be on this many medications. Let's de-prescribe you, and let's get you on a better diet, or more of this vitamin B or vitamin D, or something else to. And that I'd like to see more people go that route. Go out and find a pharmacist who's passionate about pharmacology and about what medications are truly doing to you.
That's great. No, that gives me a lot to think about. It gives me a lot to ponder and think about. What are we doing in our house with pharmacies and medicines? And are we even thinking about what's in it? And yeah, like, should you and I have the same medicine, different weight, or it's different genders, different life story? They're like, we shouldn't be having the same pills. So Todd, this is fantastic. I could talk to you all day. 100 more questions, but will we leave it there? So good. Thank you so much.
Let me leave you with a word I want you to study.
Please.
Everybody to study this word. Pharma. So say it with me. Pharma. Genomics. So I want you to say pharmacogenomics. Guess what, buddy? Well, as soon as pharmacogenomics goes full scale, and it's been bubbling for about 25 years now, because remember when the gene testing thing came out and you could find out where you're from and your ancestry? Well, back in the day, it had all the data. Like, and I think it scared pharma, and I think it scared the FDA, being like, we just told human beings how their drugs are going to affect them like to the exact way it's going to affect them. And I think they close that portal up really quick and they put it through a retroactive, vetting, which is there's very good to that. You have to make sure that things are working as intended. So the science of pharmacogenomics will become the Thor's hammer. Remember Thor and the Marvel superhero and his hammer? So that hammer will be the hammer of the pharmacist, and they'll be able to literally know to the individual how things will affect you, how molecules and drugs and substances will affect you specifically. And by the way, it's available today. The test is probably anywhere from high side is about $1,200. Low side, you could probably find it for $300, but it's a cheek swab. You take a little, like a little tissue, Q-tip, and you swab the sides of your cheek really kind of hard. You kind of rub them. You put that in a tube, you send it to a lab, and they do a panel discovery about how you metabolize things based on your DNA. And it is freaking fascinating. I had mine done. So I know what I can metabolize fast, what I metabolize slow. So if I was taking a blood thinner, for example, I would not want a specific one because it says on my PGX test, hey, he metabolizes really slow, right? It's like, here's my blood thinner. The doctor's like, gotta give him a blood thinner. And it's like, just like, I'm just going to take my time letting this drug work. Whereas you take it and it's like it just goes right through your system. Your blood's so thin. Well, don't give Eric anymore because he'll bleed out. So how would you know that difference? Physicians don't know that. They're just giving you the medication because it's designed to do a specific thing. Pharmacogenomics will tell you how fast would you metabolize and break that medication.
I need to get that test.
You should
get that test. Todd, this has been fascinating. Thank you so much for this. It's been
great.
great.
Thank you for having me.
Yeah. Thank you to my guest, and thanks for listening. Subscribe to get the latest episodes each week, and we'll see you next time.